Hi, everyone. Welcome. I'm going to give it about 30 seconds before we get started to allow additional attendees to join and get settled. All right. Welcome to the 2026 Digital Health Summit brought to you by the California Telehealth Resource Center. As you know, the theme of this year's event is Bridging the Gap, Digital Health and AI for Smarter Care, Stronger Teams, and Sustainable Healthcare. We're glad you can join us for today's session, Building What Lasts, Rural Digital Health Sustainability in Practice. I'm Amelia Ochoa Ruiz, Manager and PI for the CTRC, and I'll be your moderator for this session. Next slide, please. This session is purely for informational purposes. CTRC has no relevant financial interest or arrangement with any organizations related to commercial products or services discussed during the summit. Next slide, thank you. Just a quick reminder that you'll need to register for our remaining sessions for the day. So if you haven't already, there's still time and 2 additional sessions after this one here. We hope to see you in those sessions. Before we begin, I'd like to go over a few tips to help you navigate today's session. We are using Microsoft Teams, and you can use those Teams functions to ask questions, post comments, connect with fellow attendees, and interact during the session. This session is being recorded and will be posted to the CTRC YouTube channel. If you encounter any technical issues, please reach out to a member of CTRC either on this platform, or you can contact us at keltrc@ochin.org. And we'll hold the last few minutes of today's session for Q&A and encourage presenters and attendees to keep the conversation going. The work of CTRC would not be possible without the funding and support from the Health Resources and Services Administration's Office for Advancement of Telehealth and the California State Office of Rural Health, part of the Department of Health Care Access and Information. With that, I will introduce our speakers for today. We have Dr. Martin Entwistle, who is Chief of Medical Affairs at Marshall Medical Center. His primary responsibilities are to oversee the medical operation of the hospital and clinics, to ensure the quality of care provided to patients and families, to develop and implement strategies in support of the organization's mission to create a community where everyone can attain their highest desired state of health and well-being, through the coordinated delivery of services meeting individual needs and optimizing the resources available. He is the executive lead for Marshall's workshops facilitating the adoption and use of AI solutions and systems for remote patient management and telehealth. We also have Dr. Lily Lau, who is president-elect on the board of directors of the California State Rural Health Association and CEO of Momentous Health. She works at the intersection of rural health and digital care delivery, focused on what it takes for technology to genuinely sustain care in rural communities. Through her statewide work with the Rural Health Association, she follows the adoption barriers, sustainability challenges, and turning points that shape whether digital health succeeds across rural California. At Momentous Health, she puts that perspective into practice, delivering neuropsychological evaluations to geriatric patients via telehealth. All right, my first question is for Dr. Lau. In your work across rural California, you're seeing firsthand the pressures pushing providers to modernize, from workforce constraints to financial margins to access gaps. At the same time, digital health continues to promise increased access, efficiency, and quality. From your statewide vantage point, what trends are you seeing and how organizations are approaching digital health sustainability?
Thank you so much. Thank you, CTRC, for having me and bringing this many people who care about rural health into one room. It's a real privilege to be here. Again, I'm Dr. Lily Lau, President-elect of the California State Rural Health Association and CEO of Momentous Health. And your question really gets to the heart of it. Here's the trend I'm seeing in California. It's a real genuine shift in posture. The organizations getting this right have stopped treating digital health as a technology that they purchase and started treating it as an infrastructure they have to build and sustain. And that single change in mindset is most of what separates the programs that take hold from the ones that quietly fade. And then why programs fail, there's a remarkably consistent pattern, and almost every failure points at something you can design around if you plan from it from day one. So let me give you the whole picture. There are three forces pushing us to modernize, and then the handful of things that, in my experience, determine whether what you build actually survives. Uh, Great. So next slide, please. Great. So the first is workforce. California leads the nation in primary care shortage areas, and rural counties carry the worst of it. And it's even starker for specialists. Many rural areas have none at all. So patients lean on primary care for conditions a cardiologist or a specialist should manage. But the number that matters today isn't about shortage, it's the trajectory. Training a physician takes 7 to 10 years, and our rural workforce is aging out faster than the pipeline can fill. As the CEO of Enlo Medical Center in Chico put it, by the time we recruit a new doctor, another one is already retiring. So here's the strategic point. Recruitment is a subtraction game you're structurally going to lose. Bonuses, loan forgiveness, rural differentials, use them all, but you're still competing against every rural hospital for the same shrinking pool and against urban system that outbid you on lifestyle. Digital health is one lever that doesn't require winning that war because one provider can serve many sites. You're not recruiting a cardiologist to your town, you're borrowing access to one elsewhere. That reframe from owning the workforce to accessing it is really the game changer. Next slide. The second force is distance. And in rural California, it isn't an inconvenience. It's a clinical filter that decides who gets care. One Humboldt County patient have to travel 3 hours each way for eye surgery and then wait 3 weeks before it was safe for even to drive home. And every drive like that is a point where a patient drops off. The 80-year-old patient who can't make the trip just doesn't go. And the diabetic who just can't get a paid workday just skips the visit. And you see him 18 months later in the ED with a complication that's really now irreversible. So distance doesn't really delay care. It turns manageable conditions into crises. So improving access really means catching the patients who'd otherwise fall out of the system entirely. And that's not convenience. It's a difference between primary and emergency care and between a cost you can manage and one you can't. Next slide. The dirt force ties the first two together. And executives feel this all the time in their bones. When patients leave for care, the revenue leaves with them, and rural hospitals can't sustain service on what's left. Half of California's rural hospitals now operate in the red, up from 40% in 2019. 1 in 4 are also at risk of closing. But it's a spiral, not a snapshot. A hospital cuts a service, say obstetrics, which 17% already have, and those patients leave and they're getting care elsewhere. Their imaging, their labs, their follow-up have gone there too. So in rural health, we call it flyover. The patient flies over to local hospital for everything, and once they left it for one thing. So you don't lose one service, you lose the revenue underneath it. And each closure accelerates the next. So digital health interrupts this spiral because you're keeping the consult local, keeps the lab, the imaging, and follow-ups local as well. So you're not saving a service, you're defending the revenue base underneath it. Next slide. So those are the three forces. On paper, digital health answers all three. It creates access where there are none. It erases distance and keeps both the patient and the revenue in the community. That's the promise, and it's real. But let me be honest with the room full of people about to invest in this. The promise is the easy part. The graveyard of rural digital health is full of programs that did everything I just described and still failed within 18 months. So the rest of my time is about why and what survivors do differently. Next slide. Here's the puzzle. Take the same technology, same platform, same device, same vendor, and deploy it at two similar hospitals. At one, it's a lifeline still going great for 5 years later. At another, it's a cart in a closet within a year. Same technology, opposite outcomes. People used to assume the difference was the product. Pick the right vendor and you're fine. Well, it isn't. It's whether four things are true around the technology: a way to connect, someone to run it, someone to use it, and a way to pay. Miss one of it and it all dies. However good the platform is, it doesn't matter. And before anyone asks about where AI fits, it's powerful, but it's still a tool. It can help you run a program, but it doesn't replace any of the four. An AI scribe that nobody's trained to use with no one owning it fails the same way. The system is still the job. And so I'm going to take you to the four one at a time because each one fails in a predictable and preventable way. All right, next slide. The first is connectivity, and it's the most literal. Only about 71% of rural households have broadband at home, and that's versus 96% statewide. And here's the part that should really stop us. That rural number hasn't meaningfully improved since 2019, even after the state invested billions. So you can't assume that the patient has a connection. And where the wire exists, cost is another barrier. At $70 to $80 a month, reliable internet is out of reach for many households who need care the most. Now, we're going to have objections. We can't fix broadband. That's an infrastructure problem. Well, that's true. You can't lay fiber, but you can design programs that assume it. Instead of a home-based model that needs every patient to have good internet, you build around anchor sites. The patient doesn't connect from home at all. They walk into a local clinic, a library, or a school that provides the room and the connection, and the provider from outside zooms in. They get a private space and a trained person on site to help. The bandwidth burden sits on the institution, not the household. And that's not only a connectivity fix, it's an equity fix because it serves the patient with no internet who isn't comfortable with the tablet. And those patients are the ones who digital programs usually leave behind first. And for patients who can't reach an anchor site, you can bring connection to them, right? A cellular tablet or hotspot that works over the cell phone. So missing broadband line never becomes missing a visit. Next slide. The next two kill programs more than the connectivity ever does, and people underestimate them because they're not technical. Start with no one runs it. A grant comes in, a telehealth or a cart gets brought in, there's a ribbon cutting, and the program is handed to a nurse manager who is already running the floor full time. Credentialing the specialist, scheduling, troubleshooting the camera, chasing the no-shows, it all becomes the 11th thing on her to-do list. It runs a few months on her goodwill, then she takes another job, and that cart goes away and nobody decided to end it. It just stopped because it was never actually anyone's job. The objection's fair, right? Well, we're in the red and short staffed. We don't have a spare person for this. Right. And you don't need one. We just need to formally have it be someone's job, not a volunteer effort on top of a full-time role. What works is protected time. Carve out 10 hours a week for a coordinator, for example, that's explicitly stated on paper. You own digital health and backfill it, named, protected, resourced. And that sounds too small to matter, but it's the single biggest predictor of what a program is going to do in the next couple of years and be alive and flourishing. A named owner who survives the turnover because the role continue to persist even after the person changes. A program running on goodwill dies the day after the person leaves. Then no one uses it. That's even more subtle because the technology can work perfectly and the program still dies. This is when the tool sits next to the workflow instead of inside it. The clinician has to remember to offer it, to log into a separate system, explain it. So under time pressure, they just default to what they're already doing. The fix is really the integration. The televisit gets booked into the same screen as any other. The referral is just one click away in the EHR. The patient gets teed up by the staff before the clinician walks in. And the test is simple. When the digital option has to easier than actually not using it. If it's even slightly harder, busy people won't use it. No amount of training is going to fix that. So both failures are about people and design, not technology, which is exactly why they're fixable. The next slide. The fourth is the financial model, the one that quietly dooms even when a program is very well run. Rural reimbursement is often too thin to cover the real costs. So the program launches on grant money and it dies the day the grant ends. So plainly, a pilot that outlives this grant was never a program, it was a demo. So the discipline, before you launch, you should be able to answer what pays for this in year 3 when there's no grant. If the answer is another grant, stop and redesign. And someone's thinking, well, what's the break even? Honestly, this varies by site, by payer mix, and by service line. So I'm not going to hand you a number that's wrong for your context. The point isn't the number, it's modeling it before you launch instead of hoping. Grants are perfect for setup, equipment, workflow, training, those one-time costs. They're tracked for operating costs because those recur forever and grants don't. So the question is to design around, can we get it funded? It's what's recurring revenue that makes this self-sustaining once the launch money's gone. And I'll show you where that comes from. Next slide. So 4 failures, 4 fixes. Connect it, staff it, embed it, fund it. Connect it, provide the connection, don't assume it. Anchor sites for those who can't connect from home, cellular tablets and hotspots to reach those who can't get to a site. So the gap is designed out, not hoped away. Staff it, a named champion who, with protected backfilled time, who owns it on paper, plus trained local staff and real IT support, and the role outlives any individual. Embedded, built into how care already flows. One click into the EHR, booked from the normal screen, and the patient prepped before the visit. Easier to use than to skip it. And fund it, and this is the concrete part. Build what reimburses well. Behavioral health, for example, is a strong example in most rural settings. It's clinically excellent, and the economics work out. Pull patients across clinics so a specialist session is full. Volume is what would close the math, and use grant monies only to launch, never to operate. But the real point is really at the bottom. None of these survive alone. A funded program nobody uses still dies. A beloved program with no funding still dies. They only hold together as one connected system. And that's the shift I'll be leaving with you today. Stop thinking of digital tool as a tool you buy and start thinking of it as an infrastructure you can build. And that's the easy part. The system around it is the whole job. Next slide. So if you take one thing from today, the platform is maybe 20% of the work. The other 80%, the staffing, the connectivity, workflow, financial model, decides whether you're running it 5 years or it becomes a cart in the closet. And that 80% is entirely in your control. It doesn't take a better vendor. It takes the signing for durability from day one. And one honest caveat, the smallest sites can't build all of this alone. A single critical access hospital can't generate the volume it takes to make the math work, right? That's not a reason it can't be done though. It's why regional network models matters, where sites share the specialists, the infrastructure, and the cost. And that's where Marshall Medical is building exactly that. And I'm gonna let Dr. Entwistle take us inside of it. Thank you.
Thanks so much, Dr. Lau. Excellent insights, eye-opening data. Thank you very much for that. Dr. Entwistle, Dr. Lau just highlighted several themes emerging across California. What challenges or opportunities that were just described have resonated the most with your experience, and how are you addressing these at Marshall Medical?
Well, thanks, Amelia, and thanks, Dr. Lau. Pretty much everything that Dr. Lau outlined resonates. We experience all those, and I'm sure many people on this call have the same experience. We're facing the challenges of recruitment and retention. We heard about that. We have got challenges in staffing, the support staffing. We've got challenges in terms of the technology, the ability to acquire it and deploy it and do that sustainably. So there are many of the issues, and I'd like to run through some slides that talk about that in more depth. Maybe we'll just step back and say, what is required for rural health services in this time of very significant change in the way healthcare is delivered. Patients, communities want to consume healthcare, the way they're willing to engage in healthcare services, their expectations are all key drivers. But for my money, a key issue is how do we provide care in the community to keep patients? Dr. Lau mentioned flyover, flyby. It's very real. We're dependent on other providers, tertiary providers, for providing care, and it's not difficult for patients to get referred out, and that's where they stay. So providing care in the community is a key attribute if we want to have successful rural healthcare systems. A few things to call out. One of the areas that we experience is the challenges in providing specialist outpatient services. In passing, we filled the gap in our inpatient care with a lot of teleservices, tele-ICU, tele-psychiatry, tele-infectious disease, tele-neurology. But it's been much more of a challenge to implement those services in our clinics and supporting in the community. Partly it's the issue that Dr. Lau touched on, which is sustainability financially. The reimbursement rates make it really quite challenging. I'll talk a little bit in a minute about one of the areas that we have addressed doing that. It's really important that we share care even when referral out is required. So have our patients back again, support for home health, support for community care, wraparound services. So if we are able to maintain line of sight to our patients, then we can do that. If when a patient's been referred out and getting care elsewhere, we lose sight of the patient, it's very hard to provide that wraparound continuity of care. We've heard too about loss of ability to provide the services and generate revenue from ancillary. Examples would be imaging for cancer patients that go to a tertiary center. Infusion, we have an infusion service, and then patients may get referred away from that. So another feature that we've heard about is shifting from episodic care to continuous engagement with patients. So to be effective, we have to be proactive and preemptive. And that means not waiting till a patient identifies they need services and come to our clinic or our emergency department. Even worse, they need an inpatient admission when those were avoidable. So remote patient management and teleservices have got a lot to offer in terms of line of sight to where our patients are at and their services that they need. And then sustainable staffing models touched already on the challenges that we have to recruit and retain providers. Back in the day when I trained, many people would be solo providers in specialist care. They may be the only neurologists in the community, and they were willing to do that, and that is no longer the case, and understandably so for work-life balance. So how do we do that? Dr. Lau touched on an important feature, which is it's very difficult to do this as a single, smaller provider. There needs to be critical mass, there needs to be networks, etc. And that's one of the areas we're working on, which I'll come to shortly. Next slide, please. So some of the challenges we've just been talking about, limitations on skills and capacity. I've been talking about outpatient specialist care, our ability to support patients in the community, so community health workers, navigators, ability to provide home health services if we can't recruit and retain. Limitations with technology. Dr. Lau mentioned a number of features that are really important. I'll just call out a couple. What I call techno-skepticism, particularly in rural areas. What is that device, black box, doing in my living room? What's it listening to, etc.? So in programs that we run on a pilot basis, it's really important to build trust with patients. key way to do that is that the introduction of technology comes from your provider, not just delivered in a box from USPS. So a lot of infrastructure that's really required. Another one is that we often don't think about when we start generating data out of remote patient management, we get a lot of data and then we're responsible for it. So who's going to be monitoring inputs? So the patient that we're doing hypertension management at home, they have a high reading, we now have a responsibility for it. And sometimes we forget to think about how we have workflows that identify who's responsible and do that in a way that is not overburdensome when our providers are already facing significant amounts of workload. So it's another call out to think through in advance how you're going to do the workflows and have those as sustainable activities. Tertiary care. We're all critically dependent on tertiary care for support because we can't provide all the level of care, all the specialty areas that are needed for the patients in the community. But how do we develop a different relationship so we don't suffer from flyby, etc.? Communication, sharing care with our patients. So there's a lot that we can and should do in that area. We've all know about challenges with funding and investment. That goes all the way through from the reimbursement rates that we receive that may not pay the way and make it difficult to get off the ground and certainly drive for sustainability, but also the funding available for infrastructure, development of capacity capability. And a key one back in the technology area is who's going to pay for devices, who supports them. It's all fine if people are going to bring your own device, but in rural areas, that can be a challenge. And so that wraps back into sustainable funding that can pay not only for the services required for clinical support, technical support, but in my mind would also include the cost of the devices so we can deploy widely. Next slide, please. So the solution we're coming up with is development of a rural health network where you bring together different entities, provider entities, that can be mutually supportive because they have different capabilities, capacities, and skills. I'll give you an example. A couple of years back at Marshall, we were finding it very difficult to sustain our behavioral health and psychiatric services. And we worked out a relationship with our local FQHC, Federally Qualified Health Center, that has different and better reimbursement rates, so they could do work sustainably that we couldn't do. And it's worked out to be a great relationship where we refer, they manage. Now, despite that, they have also got challenges in recruiting and retaining staff. But it gives a clue to how a hub and spoke model could work. That's just one example. But imagine if there are more entities involved in that. So it includes others such as tribal health or a number of other hospital entities. And now we begin to generate critical mass that would make it more feasible for us to recruit and retain and spread the workload around. So that's the general model that we are working on. Now, we can also use it to fill gaps in services that are really quite challenging. And the one we're working on right now is outpatient neurology. So we have inpatient neurology. We have very high capability in terms of stroke management, neurology management, and then our patients discharged home or back into the community. And we have a significant gap in continuity of care. So we're working out how could we fill that. So our current plan is to, again, use our rural network to have a mixed model. So we've been hearing so far about use of telehealth, and for sure that's got great opportunities around neurology. But some of these clinical conditions really benefit from face-to-face consults. And so how would we develop a mixed model where we have the ability to provide face-to-face consult visits as well as tele support? So again, back to the value of a hub and spoke network model, we're hoping that we can generate critical mass amongst those in the network so that we could find a way to recruit and retain providers who work in more than one facility. And so they're doing clinics maybe one day a week in Marshall and then going to some of our other partners. And in between times, we're supporting patients over telehealth remote management. Next slide, please. So the idea behind this is to build a 5-year vision using our rural health network. So we would be using it to provide the specialist area gaps, fill those that I've been mentioning. We use it to provide support for primary care practice, such as behavioral health, ongoing care. We would use it to be able to scale up facilities for support for chronic care management, so hypertension, diabetes, behavioral health issues, etc. And the idea is that we then be able to share infrastructure, have partnerships with technology providers that we can develop scale that may give us better pricing. We could share around the tech support that Dr. Lau mentioned. It's difficult to do in a smaller single entity hospital, for example. So the vision is that we start building the hub and spoke in a smaller way, and then over 5 years, we've really got to a point that this is a sustainable model that builds at scale, that keeps patients in the community with a range of services from specialist, primary care, ancillary services, etc. It's integrated and coordinated. Next slide, please. So how are we getting there? Well, with thanks to the California Telehealth Resource Center, we were supported to do a digital health assessment last year, 2025, to look at our technical capability and readiness, look at our staff and our workflows, etc. That was extremely useful. And I would suggest that if you're trying to move forwards with an ambitious strategy, it's well worth getting this kind of assessment to see where you're at, where your gaps may be, where you could get complementary help from other partners, etc. Which leads me to the next thing, that we have been working hard on partnerships. And in our broader region, we've established a Sierra Health Collaborative. It's basically a number of hospitals in the Sierra foothills in Northern California. 5 of the providers are in California itself and 1 in Nevada. And we are working on the things I was mentioning a few minutes back. How do we mutually support each other? How do we avoid all of us trying to climb the same hill when we could be climbing different hills and support each other in that process? And that's working pretty well so far. I will say it's early days, but it's very encouraging. Particularly encouraging that since we got off the ground originally with 4 hospitals in California, 1 in Nevada, we've had 1 more join, and a couple more are very interested to join that rural health collaboration. We've also, as I mentioned, got partnerships with tribal health, FQHCs, and really good support from our county HHSA services. We've also focused a lot on developing multidisciplinary teams with a range of stakeholders internally that are doing work or have expertise in telehealth, remote patient management, AI, and care coordination. And that has proved well worthwhile because it helps us in terms of the development of our infrastructure and thinking about the very issues that Dr. La and I have been mentioning, to not forget. Think really hard about where you're going to get to and have you got the resources and capabilities to get there. It's all about creating infrastructure, not just having technology you're going to throw at the challenges. So I've mentioned pilot programs to help us get off the ground. So the partnership with the FQHC for behavioral health, El Dorado Community Health Center, I've already talked about. And then in terms of trying to understand social needs and social barriers in one of our more rural areas, we conducted a pilot, and again, this may give you some insight and clues as to ways to do this. It was a pilot that we were only targeting 30 patients. So initially getting off the ground, we identified it was important not to overstretch ourselves. So we're aiming for success. And so we did a pilot targeting 30 individuals. Could we get them to even have a tablet in their home? And could we get them to use it? And we were not doing any physiological measurement. We just wanted to engage and find out, for example, we'd connect over video with them and say, we see you have an appointment next week, or you've got a med refill next week. Are you able to, have you got transport to get that? And if not, then we could do something about it. So it's fairly simple, basic stuff. Doesn't involve complexities of measuring blood pressures, etc. And that proved very useful, some very useful insights and learnings from it. And then lastly, we've been working hard with our ACO as to how you do deliver care at scale. So 2 populations with an ability to then drive outcomes. And so a lot of learning in that about how you manage larger populations, not just think about the individuals coming to a clinic. Next slide, please. So further building blocks that we see as important in terms of that rural network, thinking about governance, how you're going to organize management, oversight. How do you organize the clinical programs? We've touched a bit on that, behavioral health, whether it's chronic care management, whether it's these specialized services, specialist services. Operations we've heard about, gets us into some of the how you onboard individuals to the programs, how you manage them within it, how you support their particular needs, and of course, delivering clinical care. And then all the issues around technology and data. Data, just a few comments, is increasingly important that you generate a lot of data out of these programs that can give you great insights into areas for improvement, performance, etc. I think there are some great AI tools to help you with one, collection and the organization of data. But again, as we've heard, AI is not a panacea. It's a support for a program that you have to think through and think carefully. Next slide. And so the idea behind the model I've outlined with a rural hub and spoke network is that if we can demonstrate that that is functional, performing, and delivers outcomes and sustainable, then you can pick that model up and apply it to other areas. And then you can begin to interconnect hub and spoke models. And that's another level of mutual support. So that's the vision in where this could go. Next slide, please. And so what I've outlined, we're excited because this has got a very close fit to California Rural Health Transformation Program, or CAL-RHT, supported by HCI, and in passing, thanks to HCI for support for this event. But there are 5 pillars for support that addresses the identified challenges: sustainable access, workforce development, innovative care models, technology innovation and connectivity. And you'll identify that those really directly address the issues that Dr. Lau brought up and the issues that I've outlined that we experience day in, day out. And I know many of you on the call will be experiencing the same. So exciting opportunity to see funding coming in order to support further activities, developments in these very important areas. So Amelia, thanks. I'll pass back to you.
Thank you so much. Next slide is going to be Dr. Lau's. Oh, the one prior. There you go.
Great. So in relation to Dr. Entwistle's mentioning the CAL-RHT, one quick thing I wanted to put on everyone's radar, if today resonated, if you're sitting there thinking, okay, but how do we actually get started? I think this would be a great next step. And it ties directly with what Dr. Entwistle just walked us through, those gaps he described and the partners you need to fill them, because none of this can be built alone, right? So on July 1st, our new Rural Connection Coalition is hosting a free webinar where you can complete an assessment, find those partners, and start building proposals for the upcoming CAL-RHTP funding. So that digital health in your community is built to last. And the registration link is right here on the slide, and I encourage anyone interested to join us.
Thank you both so much for the information you provided. I think it is timely and relevant and something that is relatable to many folks on the call. We do have one question for both of you just to kick off our Q&A. During your presentation, you both emphasized the importance of sustainability. If you could give one piece of advice to a rural healthcare leader who's just beginning to rethink their digital health strategy, what would it be?
Maybe I'll go ahead and take this one first, Dr. Enwiso, if you don't mind. I would say start with the business model, not the technology. Almost everyone does it backwards. They get excited about a platform, an AI tool, they find a grant to buy it, and they figure out how to pay for it later. And the later is exactly where the program dies. So before you pick a vendor, before you write the grant, answer what question? What pays for this in year 3 when the grant money is gone? If you can't answer that, you're not ready to launch yet. And that's okay, because figuring it out now is so much cheaper than watching the program collapse in 18 months. So the leaders who get this right treat the grant as money to build something, not the money to run something. And that one thinking helps prevent most of the failures that I see.
And I would add to it, similarly, I'd say have a vision for where you want to go to, which relates to what's the underlying problem that you're trying to solve. And whilst there's a lot of commonality across rural healthcare entities, we all have differences. So what's the particular challenge you've got? What's the vision that you want to go for? And then complement, I agree with understanding how it's going to be sustainable. It won't get us anywhere, but then fill in the pieces of the puzzle and have a pathway from getting from here to there. I think similarly, too often we hope that throwing technology at the solution or the problem will solve it. And it really takes more thought and consideration because we're back to still a humanistic process in the delivery of healthcare that involves a lot of steps and a lot of people. And how are they going to fit into this?
Agreed. Thank you both, Dr. Lau and Dr. Entwistle, for the information provided. I think we all hear you loud and clear. Technology alone is not the solution. It's much more complex than that. So moving on to the next slide. For ongoing support, make sure to check out our website at keltrc.org, where you can find events, webinars, and on-demand resources, and so much more. Or you can reach out to us directly at keltrc@ochin.org. Next slide, please. We also, on the horizon, have the California Telehealth, or the 2026 AI Cohort Series and Office Hours. This series builds on the strong foundation and success of our 2025 AI Bootcamp. We're just expanding on more opportunities for deeper learning and practical application. This event is also no cost and virtual, and it's designed to support healthcare organizations in exploring and advancing the use of AI in a way that's practical, reasonable, and aligned with real-world care delivery. As a part of today's summit, attendees have the opportunity to complete the first 3 sessions of the cohort series, and we will continue with 3 additional sessions offered in July and August, along with dedicated office hours to provide ongoing support, discussion, and shared learning. To learn more about the upcoming sessions, access resources, or register for those office hours, I encourage you to visit our Health AI Bootcamp page. We're going to drop, Crystal already dropped a link in the chat. Before we wrap up today's session, we'd like to invite everyone to complete our short exit survey. We want to ensure that we're meeting your needs and address your feedback. Your feedback directly informs what types of programming, tools, and resources we develop moving forward. So I see that was prompted there. And we also want to encourage folks to stay in the know and subscribe to our monthly newsletter to receive the latest updates on available training, webinars, and on-demand resources. I do see, not quite yet, some results pending, almost trickling in. But while we wait for those poll results, again, just wanting to thank Dr. Lau and Dr. Entwistle for the time and expertise today. Again, just really relevant, eye-opening, and very relatable information shared today. It gives us a lot to work with and hopefully innovate moving forward. Thank you both so much for your time, and thank you to our attendees. We look forward to seeing you in later sessions today.